All righty. Hey, everyone. Let's see if we can get this show on the road. We'll get everyone out of the waiting room and here into the session with us today. We've got our NPT brain dump session. I'm excited to have you all here as we get going and head into exam day this week. I do appreciate all of you taking the time to come and spend with me. I anticipate a full house today. We're going to have a very full session. A lot of questions, I know, as we head into test day. And I want to help with as many questions as I possibly can. So as we go through today, please be sure to use the Q&A feature in Zoom where you can queue up your questions for me. I'll try to get to as many as I can. Understandably, there will be lots and lots of them, but I do want to get to as many as I can. So the target for today is to go for about 1 hour. I'll mention this again here in just a sec, but as we get tuned in, if you don't mind, head over to that chat box, make sure it's going out to everyone and just give me a quick, number one, sound and video check, but let me know where you're tuning in from. Where is it that you're tuning in from? It's always interesting to see where everyone is. So I'm broadcasting to you from the great state of Idaho. Any of you who've been to Idaho or on the way to like Yellowstone National Park, I'm in that general vicinity. See, we got folks from Wisconsin, Arkansas, Nevada, Kentucky, Georgia, Utah, Virginia, Illinois. Do we have any international participants? Always kind of fun to see that. Florida, we've got Georgia, Kansas City, Delaware, Tennessee. Awesome. South Africa, excellent. Welcome, welcome. So glad to have you all here today as we go through some of the things that you could use and need on test day. So let's talk a little bit about the plan for today. So the plan, I do anticipate we'll go for about 1 hour. So 1 hour today, going to be targeting, we won't do a ton of practice questions together. It's kind of, the structure of today's session is going to be primarily mnemonics, ways to remember things, little tips and tricks that often show up on questions so that you get hopefully another 5 or 10 or 20 right as a result of coming to visit with us today. So a couple of questions that come across. Is there a PowerPoint slide deck you can follow along with? Yes. So I just posted it over in the chat box. So if anyone tunes in late and asks, hey, where are the slide decks? Would one of you please copy and paste that for them just so that everyone can have access to that? Plus, question comes across, is this brain dump session applicable to PTAs or just to PTs? And it's absolutely applicable to all PTAs and PTs because we're talking about mnemonics and things that are clearly important and you should remember for test day. So that's the plan. We're going to talk about your test day experience a little bit, talk about some of the key information to put on your brain dump. When I talk about brain dump, what I'm talking about is that scratch pad or the scratch paper they give you at the test center. Now, you cannot bring any outside materials, so this all has to be in your mind as you walk into the test seat. However, it's super helpful to be able to jot down a couple of notes, do a little bit of math on that scratch pad. And I've found that over the years, there's just, it's such a good calm down experience to be able to have a few things written down, you know you're not going to forget. And it really calms the whole experience so that you can be more focused and mindful on the questions you are working on and not be so worried about forgetting whatever key item you're trying not to forget. So ideally, you will prepare ahead of time what you'll put on your brain dump. And then today we'll just talk about some of the fun things you could put on there. All right, so we'll talk about some of the math on the test. We'll talk about just some key tips that will help you on test day. But let's start first with test day and test taking strategies. So when it comes to taking a large standardized test like this, it's critical to start, obviously, with a good attitude. I'll talk about more of that as we get kind of the soft skills as we get to the end. But when it comes to test taking strategies, among them are making sure your mind is in a good place. You want to make sure your timing is adequate. So targeting about 1 hour per section. Now, obviously, there's some flexibility there for your entire test day experience, but part of it is using the scratch pad or the brain dump. And so we'll talk about some of those items. What's interesting is there's a question that comes up as well about this in the Q&A or in the chat box. The question is basically, what can you take to the test center with you? So on test day, you are permitted to take a water bottle. So this is something that was new at the beginning of last year. So you are permitted to take a clear plastic water bottle. I don't have an example sitting with me here, but a clear plastic water bottle with no writing. You can take that right to your desk or to your test seat. Like when I took the test, that was not permitted. They didn't permit any food or drink in the test center itself. You had to leave that all in a locker. But you are permitted to take water with you to the test seat. Now, again, it has to be in a clear plastic bottle, no writing. So what I saw some silly meme the other day of someone who had replaced the label of a water bottle with cheat sheets and notes. They will not permit that. So you just have to have a clear plastic water bottle devoid of all writing. you can take that into the test seat and actually have a little bit of hydration while you test, which there's a strong correlation between hydration and mental acuity or mental status. Other things you can bring with you to the test would include a snack. Now, that you'll have to leave in the locker. So they give you a little locker, they give you the lock. So basically, they assign you a locker and they say, all right, stash your stuff here and then come take the test. I recommend very much that you prepare what you'll eat on test days. So, like something with fats and proteins in it, not just sugar, because you don't want to have a sugar crash on test day. So that's why some of you have heard me say this before, but that's why I tell people just plan on something like a trail mix, something with some fruit, some fiber, some proteins. It could be a sandwich, whatever it is. But you have to leave that in the locker along with any medications and all of your like your cell phone and your coat or whatever it is. It's July. I guess you don't need too much of a coat, but anyway, you stash all that and then you walk into the test seat, and we'll talk a little bit more about that as we get to the end. All right. So other things I want to talk about today is so obviously this is the brain dump, things where you can jot down notes. What's interesting to me now, you'll have to report back to me what your exact test experience is. But what's interesting to me is that it does vary a little bit by test site. Now, this is something that's a little annoying to me. Some test centers permit you to start writing as soon as you start the tutorial part of your test. Now, the tutorial part is where they show you how to advance through the test, where to click, how to advance through the sections. It's all very routine, but just so that you're familiar with the software itself. I've had some students report that they can start writing on their brain dump immediately as soon as that tutorial starts in their test seat. I've had other students report that as soon as the test begins, so they see question one is when they can start writing on their brain dump. So I just double check with test staff to make sure that you're doing everything above board. You want to make sure you're doing everything by the book. But I do find that it's a little bit funny that's somewhat variable by test center. Now, as far as the official policy, my guess is it's probably start as soon as you see question one. But there, again, you're already in the seat. You're taking the tutorial. It's not like you're getting any outside source here. It's just your brain. So check with your test center before you start jotting down. You just want to make sure you're totally above board on that. Other things, just as far as free resources that you have, obviously we're just a few days before test day. But those of you who are taking it down the road, maybe towards October or January, the NPT podcast, that's a podcast where we go through a practice question in pretty much each episode. Short form practice question with a long explanation about why it's right, why the other ones are wrong. It's a super great way to use your found time, in the sense that when you're running, when you're out for a walk or driving, whatever it is, you can listen to the podcast. And then just by raise of hands, I've got my VIPs here, my VIPTs. So each quarter I run a VIP course, and my VIP course is dedicated to my VIPs. So the VIPs, we meet twice a week. We go through tons of practice questions. We have a private messaging group. We talk about questions. We talk about content. Again, I feel like it's something that's extremely helpful. It's a 12-month access. So those of you who are targeting down the road, I think you'll really enjoy it. That's our VIP course. And we'll be starting that here in a couple of weeks as we reset and go for the October course, for the October test date. All right. So as we get going here, what questions do you have about today's session? Like I said, we're going to talk about some of the things that show up on an effective brain dump, key acronyms and mnemonic devices. Question comes across, can we bring Red Bull or some type of caffeinated beverage into the test seat itself? The answer is no. They permit only water in a clear plastic water bottle. Now, obviously, there are a lot of things that are very clear liquids that they're not going to taste test it or put it through some type of detector. But I find that caffeine, plan how much caffeine you're going to use that day, just because over caffeinating comes with its own downsides. So just be very cautious about that. That's all I want to say there. Let's see. Other questions. Is there a dress code for the testing site? Dress codes, like, can you wear a swimsuit to the test site? I've never heard of that happening. The dress code itself, I'm sure there's something somewhere, but my suggestion to you is to dress to impress. So you're going to dress like you're the boss. PTs, we are extremely good at dressing comfortably and fabulously. So my suggestion is to dress comfortably and fabulously. But Emma brings up a good point about dress for test day. I forgot to mention this. Test centers are notoriously cold, and that's because they have to have the air conditioners going because all the computers are running. So therefore, I suggest layers, especially if you're prone to getting cold. bring an extra layer of some kind just in case you cool off. And anyway, they're just notorious for being extremely cold environments. And so that's the key. So dress in layers. That's what Aaron says. I've been told to dress in layers. Christian says, how early would you get there beforehand? I'll say this, get there early, but not too early. So my suggestion is 30 to 45 is probably right at the border. If you're there 10 minutes ahead of time, it's a little bit fast. If you're there 2 hours ahead of time, then you're just going to kind of veg out in the parking lot. So 30 to 45 is a good target. Give yourself a little leeway. That's what I would do personally. Let's see. Caitlin says, can you wear jackets with pockets? I've heard you can't have pockets. No, that's not true. You can have pockets. You can wear a hoodie. You just have to show and turn out all your pockets before you walk into the test seat. And so like when I took a test, I've taken 3 prometric tests in my life, an NPTE, and then I took my OCS exam on a prometric side as well. You have to lift up your pant cuffs and show your socks. You have to turn out your pockets. They double check all the edges of your sleeves, make sure nothing is hiding anywhere. And as you turn out your pockets, I just very, very quickly, not to digress too much. I did have a story from a few years ago. I had a student who, she walked in, she had a hoodie on, and she was taking the test, and she realized about halfway through her first section that she'd left her phone in her hoodie pocket. Now, I want you to think for a moment, what would you do in that case where you had genuinely just forgotten that your phone was in your hoodie pocket? Well, so she sits there and she starts fiddling it with her hand, and she starts thinking to herself, well, I used my phone for a timer feature while I was practicing. What if I just pulled out my phone and used the timer on the phone? There's nothing wrong with that, right? So she carefully pulls out her phone in the middle of the test, starts using the timer feature. So she's like hiding, huddling down, pushing the buttons. And one of the proctors caught her and, hauled her out. I don't know if they hauled her out, but they discontinued the test and they said, all right, we're going to send you for review. And what surprises me is that she was only barred from taking the test for 2 years as a result of that incident. I thought they'd bar her forever just because they found test material on the phone. It's just kind of a crazy story. So all that being said, make sure your pockets are empty for your sake as well as for the test center's sake. You just want to make sure that everything's empty. All right. Let's see. Question comes across the jewelry, like no smartwatches. They're not going to let you have smartwatches. That you can bring your own earplugs, but it's best if they're already prepackaged, just little foam earplugs. They just don't want any electronic earplugs, no noise canceling devices at all. Let's see. Sydney says, can you take lotions that it's essential oils? I've never had anyone ask about lotions, but I suppose you could take it to your locker. You can't take it to the test seat, but yeah, they're not going to let you do much of lotion there. All right. So let's see. Let's talk about some of the key effective brain dump items here. And just as a quick follow-up here, question says, can we take a visit to the test center a day prior to the exam? Yes. So you can go visit. They'll give you a little tour. Not much of a tour. They'll say, yeah, check in here, take your test there. It's not a giant tour, but at least you'll see where the test will be and hopefully take some of the jitters out. All right. So as far as some brain dump items, this is what I suggest here. So let's just go through a couple of brain dump items here. So let's start with my maybe not so famous, but infamous 666 rule. So the 666 rule, this saved my bacon as a new therapist just because I was trying to memorize protocols. I was trying to remember when to do what when it came to intervention strategies for patients. And I discovered pretty quickly, this is the same in Kisner. It's the same in McGee. Whenever you see rehab protocols, they typically follow a 666 protocol, meaning that the first 6 weeks, this is what's called the maximum protection phase. Now, what does that mean? Well, that means that typically, can't spell here. So the first 6 weeks is maximum protection phase. What does that mean? Well, that means that you're taking really good care of the tissue. You don't want to overload it, don't want to activate it. You'll typically see this in like a rotator cuff surgery or like an ACL surgery, an Achilles tendon repair. You're taking really good care of the tissue so that you don't disrupt it. So typically during your maximum protection phase, you're working on the surrounding joints. You're doing passive range of motion, but only to a limited degree. You don't want to stretch the tissue. So typically quite limited during max protection. The next 6 weeks, this is where PTs really shine. It's what I call the moderate protection phase. And again, you see this as a common theme in so many of the rehab protocols. The second 6 weeks, this is where you're doing progressive loading. You start with active range of motion and progress towards resisted range of motion So we'll use that acronym, resisted range of motion, as you progress towards more functionality. So the first 6 weeks, maximum protection, second 6 weeks, moderate protection, and then finally the last 6 is 6 months. If anyone ever asks you, when will they be able to return to sport or return to high velocity, high load activity? Usually and almost categorically, you'll see that it's a 6-month mark, 6 to 9 months or 6 months and beyond, high velocity, high load activity. So for instance, I have a good friend who just had a massive, it was a sternoclavicular dislocation that was surgically repaired. And he was wondering when he could return to competitive pickleball. Have any of you had pickleball patients yet? Seems like pickleball is a very dangerous sport. In any case, so he had a pickle. Well, it wasn't injured during pickle. Well, no, was it injured during pickle? Anyway, pickleball injury, sternoclavicular dislocation with surgical repair. And his question is, when can I return to competitive pickleball? And the answer is going to be 6 months. It's almost categorically going to be 6 months by the time that repairs enough and the muscle strength is sound enough to be able to return to full high velocity, high load. So this helps on your test questions. The reason I tell you this, it helps us on your test questions. Look at the time frame from surgery. So let's say they had a surgical repair and you're 2 weeks out. What are you going to be doing? Well, maximum protection. You're going to not overload the tissue. If you're into the 6 to 12 week mark, at that point, you're starting to do progressive loading. So that's why the 666 rule, again, saved my bacon so many times, because I knew generally what I needed to do in each case. And then obviously you look at the surgical protocols for specifics, but this was a good, really good start. Let's see. Mara says there has been a practice question asked about return to sport, and 6 to 9 months option was incorrect. The answer is 9 to 12 months. What happens if you're given both these options? I guess it depends on the severity of the injury. Obviously, don't you hate it when professors tell you that it depends? But most of the time, like an ACL protocol, pretty much every ACL protocol says that there is a potential return to sport at 6 months. Some push it to 4.5 months, but again, it's almost always going to be 6 months or beyond. Jessica says, could you give some examples of injuries or surgeries that wouldn't follow the 6-month rule and require more time? They'd be more minor injuries. Typically, they'd be like tissue removal. As an example, like a meniscectomy, partial meniscectomy. It's one of my favorite rehabs because a partial meniscectomy does not require as much protection because you have not repaired a tissue. You simply carved out a little bit of the deranged tissue. So a debridement type surgery, things where there's not an actual repair. Yeah. Examples like that. So I suppose meniscectomy is a really good example. Let's see. Christopher says, this is my second attempt. I did my undergrad and DPT 3 years, 11 months, had 2 kids, and been working 2 jobs. The things on the slide have helped me learn and remember this info better than any other source. I'm on board with the Crane Train. Yes, the Crane Train. Love it. 666 rule is a really hard topic for me to grasp. Excellent. All right, so other items I wanted to talk about, just some little acronyms or mnemonics here, is the acronym SALUTE. If this seems to show up on the test pretty frequently, the upward rotators of the scapula, serratus anterior, the lower, and the upper trap. So if you're going to raise your hand to salute, you go upward rotation. That's the serratus anterior, lower trap, and upper trap. The downward rotators, this one's not nearly as fun. If you love ramen, so it's the levator, the rhomboids, and the pec minor. So I don't know, the levator, the rhomboids, and the pec minor. If you love ramen noodles, I've got a 14-year-old son who's really into ramen noodles. That's like his favorite thing. He'll do a double ramen noodle batch like every day. So getting ready for college, I guess. Other things, these are just other little special tests that helps me remember things. O'Brien's test, it's testing slap tears. O'Brien's test, you go from a pronated position to a supinated position. And in my mind is saying like, oh, that's better, meaning it's worse in pronation and better in supination. That's O'Brien's slap, superior labrum test. Jurgensen's test, similarly, it's you have your arms, your elbows at 90 degrees and you turn again a similar position, but you're activating the biceps a little bit more. And so Jurgensen's test is testing for biceps tendonitis. And you say, why am I doing this? If you turn your hands up, near your ear, painful arc test. Painful arc test, I feel like this shows up on every single test. Painful arc test simply looks at, all right, as you raise your arm from 0 to 180 degrees, if you have pain in the painful arc from 60 to 120, what does that indicate? So I'll ask you that time, what does that indicate if you have pain in the 60 to 120 mark. Typically, that indicates subacromial impingement syndrome or some type of impingement, subacromial impingement syndrome. So if you have pain in the 60 to 120, that's going to tell you likely that you'll have subacromial impingement syndrome. If instead you have pain between 170 and 180, what does that indicate? 170 to 180, typically this AC joint. The way I remember that is the AC joint is typically tested with adduction. So if you smash the AD joint or adduct the AC joint, it provokes pain in the acromioclavicular joint. So this is an example of what you could draw on your scratch pad. You could draw the painful arc test where you have subacromial impingement syndrome in 60 to 120, and then AC joint between 170 and 180. So just an example of a quick little drawing that will help you on test day, especially if they give you a picture. All right, so there's a question. I feel like this is a great segue. Someone asked, who was it that asked the question about this? Question about, Philip says, do you have time to tell us the protraction and retraction of the scapula? So I feel like that was a great segue there, Philip. So we talked about the salute, the love ramen or the levator scap. Protraction, retraction. Protraction is primarily done by serratus anterior, and retraction is primarily done by rhomboids. Now, clearly there'll be some crossover, a little carryover in the muscle groups. However, protraction and retraction are done by those muscles. All right, so other things I want to talk about here as far as brain dump items. This is one that seems like, again, I can almost guarantee this is going to show up on the test. Medial border winging or scapular winging is typically caused by serratus anterior loss. So serratus anterior loss, we're talking about loss of the serratus anterior. So you lose that medial border stability, so you get that medial border winging. So if on the test they say, if they just say scapular winging, you'll say to yourself, all right, scapular winging, that's got to be serratus anterior loss. If instead they say something like lateral border winging, they'd have to be very specific here, very, very specific here. Lateral border winging, where the outsides of the scapula have winged out, that is much less likely, and it's caused by trapezius loss or spinal accessory nerve, cranial nerve 11. So if I were to remember one thing, I just remember serratus anterior with the long thoracic nerve is responsible for scapular winging. And then I'd understand the interventions, which are like push up with a plus, something where you're doing protraction of the scapula. Christian says, do I have any pictures of these two loaded up? I don't have any pictures. Try to show with my hands, medial border versus lateral border. In the VIP class, we showed a lot of pictures. I'll see if I can track one down. All right. Other things I want to talk about, kind of shifting to the spine now. I want to talk about some fun little acronyms you could put here. So the vertebral artery test, a fun acronym I have for that is VOA. The vertebral artery test tests the opposite artery. So if I were on the brain dump, I just write VOA. What does that mean? Vertebral, testing the opposite artery. So therefore, it means if you rotate to the right, you're testing the left side. If you rotate to the left, you're testing the right side. So vertebral opposite artery is a good target for, or a good little mnemonic you can put there. Other things, the alar ligament test, there are some nasty questions. I saw this awful question. It asked about when side bending C1 on C2, when would you expect to see movement of C2? 0 degrees, 2 degrees, 4 degrees, and 6 degrees. It's like, what? Like, who remembers that? So the correct answer is that C2 should move immediately with side bending of C1. They're connected very tightly by these alar ligaments. That's what these guys are, these alar ligaments. They're connected so tightly that you should see immediate movement. So as a silly little acronym or mnemonic here is all or nothing for the alar ligament, that as you side bend, you should see immediate movement of C2 with C1. Excellent. Let's see, a couple let's see, Amy, there's several mentioning this as well about the acronym SALT. We should put that here. SALT for the serratus anterior innervated by long thoracic. So if we're going to do salute, so salute to upwardly rotate the scapula, we better say SALT for the long thoracic nerve, which innervates serratus anterior. Excellent. Excellent. Really good. All right, question comes across. There's a PDF available of the slide deck. Am I able to send it out as a PDF? So if you just go to the Dropbox link, you should be able to pull up. Otherwise, at the end of the session, I'll also try to pull up a different, I could try to put it in Google Drive or give it in a different way. All right. Sharp pursure test. This is one where it's a relocation or a reduction maneuver. And I always think of pursed lips. If someone's trying to kiss you, I don't know if any of you had this experience. If they're trying to kiss you and you push them back, so you push on their forehead, that is what the sharp pursure test. And it is a reduction maneuver or a reduction in symptoms with sharp pursure test. So I don't know if that helps at all, but sharp pursure test, I think about pursed lips. And you push, if they're coming at you to kiss you, you got to push them back away. That's a sharp pursure test. Question comes across, is sharp pursure for the transverse ligament? Yes, sharp pursure test is for the transverse ligament. Lizzie says, so is the answer 0 or 1 degrees? It is 0 degrees, meaning that with immediate movement, or you should see immediate movement of C2 on C1, just because they're connected so tightly. So that would be an example of the alar ligament. So Lillian says, if C2 doesn't move, is it indicative of an alar ligament lesion? Yes, that's exactly right. So if you move C1 and C2 doesn't move, that tells you that it's too lax. The connection has gone bad between C1 and C2. All right, so I wanted to ask you this quick quiz question because this is something that seems to come up fairly frequently on test questions. What conditions potentially could cause a transverse ligament laxity? So obviously trauma is on the list. So I hope you all put trauma on the very first of your list. But what other conditions can cause this? Now, there are 5 main ones, and there's a bunch that could fit on this list as well. And most of you are getting this. Pregnancy, Ehlers-Danlos, rheumatoid arthritis, Marfan syndrome, Down syndrome. These are very, very high on the list. And the one I'd have you remember especially is rheumatoid arthritis, because it feels to me, I don't know, maybe it's just me, that as I think about rheumatoid arthritis, I'm usually thinking hands, non-weight bearing joints. I'm thinking about bilateral presentation. I'm usually not thinking about the neck. Now, transverse ligamentous laxity is common, or destruction of synovial joints is extremely common in rheumatoid arthritis, which is likely to cause transverse ligamentous laxity. And then just of note, I'm trying to think how to phrase this question because I've seen it. I just saw it come up again. Rheumatoid arthritis, what is the most common medication used for rheumatoid arthritis? Now, probably the very, very most common is non-steroidal anti-inflammatories. All right, so let's go to second most common. Second most common is something called methotrexate, which fits in the category of disease-modifying anti-rheumatic drugs. All right, so we got DMARDs. Now, this is the goofy part, and Lillian already brought this up. The goofy part, that methotrexate is a gold salt or a gold therapy. And the first time I saw that listed as an answer option, I thought, oh my goodness, that's got to be the outlier. Like, I don't know, they have gold fever. I don't know, I'm thinking about the people, the gold rush type people. But no, the compound for methotrexate actually has gold in it. And so methotrexate, as an extremely common DMARD, has gold or is a gold salt. So therefore, my suggestion is to always remember that these rheumatoid arthritis folks, they are good as gold, right? Just as good as gold. I don't know. That was a goofy one, and I don't want anyone to ever forget that. All right. Second thing I want to ask you is, let's say you have a patient with Down syndrome. So this is another one that comes up all the time. Patient with Down syndrome, what counsel do you have? Counsel to parents about activity? About activity. What activities would they be not would they not be permitted to do? So what can they not do? So anything where they tuck and roll, so like a somersault. So somersault. Anything like contact sports, we're talking about peewee football, trampolining. How do you feel about trampolining, right? Trampolining, so you would avoid that. All of this is due to the transverse ligamentous laxity or the atlantoaxial instability. All these things would be extremely contraindicated. You would avoid contact sports, anything with severe or very sharp neck movements are very, very, very much to be avoided. So gymnastics, somersaulting, contact sports, you'd avoid all that. In a child with Down syndrome, you'd counsel the parents about activity like that. Excellent. So those are the most common ones: rheumatoid arthritis, Down syndrome. It is possible you could see a question about Ehlers-Danlos or Marfan, where you have general ligamentous laxity, pregnancy, kind of the outlier there. But yeah, all these are potentials that could show up on test day. All right, talking now about another key topic that seems to come up on test day all the time is active and passive insufficiency. Just to briefly define these: active insufficiency, the inability of a two joint muscle to complete full range full active range of motion, and then passive insufficiency is you can't do full passive range of motion. So, my favorite example, some of you have heard me say this before a million times. I want you all to do this. Make me a nice fist. Everyone, show me your good fist. Now I want you to do it again, just this time in full wrist flexion. Now show me a power fist. And you'll find it just does not work. So my question to you is, at what wrist position do you get the best grip strength? At what wrist position do you get the best grip strength? So usually it's about 30 degrees of extension. So the test question will say something like this. A patient is lifting a heavy suitcase from the floor. As they lift the heavy suitcase from the floor, what direction will their wrist move, or what position will their wrist be in? Well, to lift a heavy suitcase, you need a powerful grasp, which means you're going to put the wrist in about 30 degrees of extension. And that's an example of active insufficiency. If you go into wrist flexion, you just don't have any strength. So you got to go into wrist extension to have a good strength. All right, passive insufficiency. This is the inability of a two joint muscle or a multi joint muscle to complete full passive range of motion. For me, the classic example is hamstring length, that if you're testing someone's hamstring length, you'll find that with the knee straight, you can only complete a certain amount of range of motion. But if you bend the knee, you'll find that oh my goodness, their foot is very long. Their head is very small, but you find that you can complete more range of motion when you bend the knee. This is an example of passive insufficiency of the hip extensors, the hamstrings, that you have to put them on slack in order to move the hip into full flexion. So now my follow-up question, it's not very tricky, but it is my trick question. Can passive insufficiency ever be helpful? Can passive insufficiency ever be of benefit to the patient? And the answer is yes. The answers come in spinal cord injuries, that a patient with the tenodesis grasp, this would be someone with a C6 injury. C6 injury, they'd be able to extend their wrist, and they need to have tightness of their flexors. So as they extend their wrist, they're able to get the tenodesis grasp. You also want to maintain tightness in the hamstrings and quadratus lumborum. And this is so that as they sit, they're able to stabilize themselves in a long sitting position. So in long sitting, you want to have about 100 degrees of hamstring length, and then you want to keep the quadratus lumborum. You want to keep that nice and tight so that they don't just flop forward. They need to be able to sit up a little bit better. Excellent. So yeah, the back extensors and the hamstrings need to be kept somewhat tight so they can maintain that long sitting position without folding in half. All right, so there you go. There's your little trick question for today, at least for that. All right, I want to talk about, just mention this very briefly. Normal pulse grading is 2+. I know there's a lot of debate about that, but that's what shows up on the PED exam, and I just memorized that. 2+ is normal for your pulse grading. I had to mention that. Let's talk about cranial nerves here for a moment. So cranial nerves, they are going to ask you about these. There won't be a ton of questions on these, and that's the annoying part, is that they'll ask you like 2 questions on cranial nerves, and you'll have memorized all this data about cranial nerves. But at the same time, you want to get those 2 questions right. So this is where you can memorize or put some type of mnemonic about how you memorize the cranial nerve. So when I was in school, we did "On old Olympus towering top, a finely vested German viewed a hawk." So there's some other ones here. "Oh, once one takes the anatomy final, very good vacations are heavenly." That's another example of that. There's some less G-rated versions of these, and we won't talk about the less than G-rated versions. Other ones here. This one, the "Some Say Merry Money," is all about the M's, S, M's, and B's, and that's what's being shown here in the sensory, motor, or both as you go through all of these. But some say merry money, but my brother says bad blood, merry money. And there, again, are some less G-rated versions of that you can memorize. But in any case, it helps you to know what the function of each cranial nerve is as you go down the list here. So as an example of what could show up on the test, they could ask you something about the pupillary light reflex. This involves 2 cranial nerves. And I'm going to ask you a question here. The pupillary light reflex looks something like this. You got your 2 orbits, so there's your eyeballs. You introduce a fuzzy flashlight. So you introduce light into one eye. So this is the stimulus. You should see a consensual response or a constriction of the pupils in both eyes. So both eyes should respond to the light. You see maybe a more pronounced one in the ipsilateral side, but you'll also see a constriction of the pupil in the contralateral side. That's what's called a consensual response. So my question to you is, let's say that you introduce the light stimulus, that's what's written here, light stimulus to the right eye, and observe a response in the left pupil only. So let's say you introduce into the right eye, but only get a response on the contralateral side. What's going on? Well, we know that cranial nerve 3 is involved in the response, and cranial nerve 2 is involved in the detection or the sensory of the stimulus. So if you're not responding on one side, that tells you have a cranial nerve 3 loss, or the response is lost, but you can still respond on the other side because that other side is fine. So I guess what I'm trying to say is that the sensory cranial nerve 2, optic nerve, detected the light, but because you could not, so in this case, you observe a response in the left pupil only, that means that only the left side response is working, the right side is not working very well. So then the last question here is, if you introduce a light stimulus to the right eye and you observe no response, what's the problem? So let's say you introduce the light to the right eye and then there's no response at all. Well, that tells you that it was not detected. So therefore, it's a cranial nerve 2 loss. No sensory was detected. And so therefore, you can't have a reflex if nothing was detected. The stimulus was not detected. So that's a cranial nerve 2 loss. So I'll write these down. So we got a right-sided cranial nerve 3 as the answer to that one, and then a right-sided cranial nerve 2 as the answer to that secondary question. By the way, this follows the same principle for the corneal reflex or the blink reflex. So where you touch one eye, you get both eyes blink. Cranial nerve 5 and cranial nerve 7 for the corneal reflex as well. All right, just wanted to mention here briefly about what the cranial nerves do. So lateral strabismus is kind of a funny word, but it seems to show up on the test pretty frequently. Lateral strabismus means the eye is deviated laterally. So therefore, what muscle is lost? If it's deviated laterally, that must mean that the medial rectus is lost. Medial rectus is innervated by cranial nerve number 3. So someone with cranial nerve 3 loss, they'll have lateral strabismus. What about medial strabismus? What if the eye is deviated medially? Well, in that case, if the eye is deviated medially, you've lost the lateral rectus, cranial nerve number 6. And so this is where things get a little bit funny. I just want to mention this very briefly. This is where things get a little bit funny about cranial nerve number 4, trochlear nerve. We've all memorized that the trochlear nerve innervates the superior oblique muscle. Superior oblique muscle. Oblique, there's an L-I, so oblique muscle. Superior oblique muscle of the orbit, which pulls the eye down and out. So pulls the eye down and out. Most textbooks say that it's down and out. That's just the way the superior oblique muscle works. But because abducens also pulls the eye out, so it abducts the eye. How do we distinguish between abduction and down and out? So we got inferior translation and abduction, or just abduction. So the best way to test for your cranial nerve 4 is to test it. This is critical here. You test by going down and in. So if you're doing H pattern testing, you look for the eye to come down and nasally. That would be how you would detect a cranial nerve 4 loss. And it's, for me, that was always confusing because we memorized about superior oblique, but then we'd memorize the test. And it's because you're trying to distinguish it from cranial nerve 6 that the test is done down and in. So down and in. Excellent. Tyler asks a good question that I'm not sure I've got a great answer to. So if you lose cranial nerve number 4, will your eye deviate up and in? Will it deviate? Will you get a deviation with loss of cranial nerve number 4? You'll mostly have difficulty bringing the eye down and in and down and out. So you'll have difficulty with the loss of the superior oblique muscle. It's usually compensated pretty well by cranial nerve 3 and cranial nerve 6. So it's not like you'll see this huge strabismus one side or the other, but and I've never seen it described like that. But again, there's certainly a lot that could be said. Excellent. All right. So those are some cranial nerves. Jessica says, can you explain why you test down and in again? It's because you want to avoid the bias from abduction or from the abducens nerve. So abducens is pulling the eye out. So you want to avoid that because you have to test cranial nerve 3, 4, and 6 when you're testing eye movement. And so to eliminate cranial nerve number 6, you test the eye down and in, and it tends to help you distinguish between cranial nerve 3, 4, and 6. Because you can test cranial nerve 3 with the pupils, you can test cranial nerve 4 down and in, and then you can test cranial nerve 6 with abduction. You can test all of them a little bit separately in that way. All right, speaking of cranial nerves, this is something that's, again, saved my bacon a few times. This is a little acronym that helps me to remember where the cranial nerves originate. It's kind of a funny little saying. You say, see my pons medu. See my pons medu. So see my pons medu indicates that cranial nerves number 1 and 2, there's 2 letters in CE. First 2 cranial nerves come from the cerebrum. Second 2 from the midbrain, 5, 6, 7, 8. So the next 4, so PONS, there's 4 letters in pons. So 5, 6, 7, 8 come from the pons or the pontine lesion, or pontine lesions would cause those. And then medullary lesions or the medulla is where you get 9, 10, 11, and 12. So therefore, pons or see my pons medu is a great way to remember where each of the cranial nerves originate. So then you can do a little deduction on test day. They say you have a pontine lesion or a medullary lesion. That will tell you that you are having difficulty with these cranial nerves. And you look for those types of symptoms in your answer options. Excellent. So again, quick little way to remember all that. There was a question that came up. I thought this was a great question, so I decided to throw in this slide. A question came up about nystagmus. And the funny part about the question, let me see if I can pull it up. Funny part about the question, I think this was from Zach, that said that that nystagmus made his head spin. And so I felt like I needed to put this in here. Here's a little table that tells you about all of the different directions and versions of nystagmus that occur with benign paroxysmal positional vertigo, or BPPV. So the ones I'd have you memorize, it feels like there's a lot on this table. The ones I'd have you memorize are the posterior semicircular canals. The posterior semicircular canals. This is where like 85% of all BPPV occurs. It's extremely common. It's the one most likely to show up. The posterior semicircular canal, that's SCC, posterior semicircular canal, has 2 branches. You've got the canalithiasis and cupulolithiasis. Canalithiasis is where you have too many otoliths floating in the canal, and cupulolithiasis is where you have too many otoliths stuck to the cupula. In any case, in either case, you'll get this upbeating torsional. Now, if you remember nothing else here, I want you to remember this word, torsional. Torsional means that you are seeing a rotation of the orbit as it goes up. So if you look at the pupil, it'll be twisting as it goes up. Upbeating torsional indicates some type of peripheral lesion. What do I mean by peripheral? It means that it's caused by something peripheral to the brain. It's not a central lesion. A central lesion, so I'll just put this up here, a central lesion. So this is like a traumatic brain injury, spinal cord injury. Central lesion is going to lead to pure upbeating or pure downbeating, but it doesn't matter really. Pure movement of up or down is going to be a central lesion. So we're talking about like TBI, talking about CVA. So something that's very central, you get a pure upbeating nystagmus that could occur. So that's central lesion. These ones are peripheral lesions because they have a torsional component. So upbeating torsional, classically for the posterior semicircular canal, treated with the Epley maneuver or the Semont liberatory maneuver in the case that the otoliths are stuck. When it comes to the anterior semicircular canal, I would not worry about that. That's like less than 2% of all cases, but it's a downbeating torsional. And then the horizontal semicircular canals, these are the ones that are tested with the roll test and the barbecue roll maneuver. That basically you just have the patient supine and you roll to one side and roll to the other side. And you just look to see which way the eyes beat. If they beat toward the affected side, then it's canalithiasis. If they beat away from the affected side, then it's or called agiotropic. That's cupulolithiasis. But again, if I were to remember just one thing, I'd remember torsional and I'd remember the posterior semicircular canal. So that's the little take-home point from this slide, is to make sure you understand that difference between peripheral and central lesions when it comes to dizziness and vertigo. And so there you go. Caitlin says, is that the same as pendular? That's a good question. I did not see that in the text, the term pendular. Pendular indicating a pendulum type movement. Yeah, I'll have to double check on that one, Caitlin. So I'm not sure I've got a good answer for you there. All right, let's see. Lillian says, could you talk about the head shaking nystagmus and the canalith repositioning maneuver for horizontal canal, how to perform it? The barbecue roll is basically you just roll them all the way over. You have them supine and roll them all the way over. And the head shaking nystagmus is where you well, I guess it's more of a corrective saccade, but basically you test the horizontal semicircular canal by moving the head quickly to one side, and you should see the eyes. The eyes should fix on a fixed point gaze. That's what normally you should be able to do. If you can't, or you see nystagmus with that, that tells you there's a horizontal semicircular canal issue. Sometimes it's called the head impulse test or the head impulse test or head shaking test, head shaking nystagmus. Jaquetta says, can you please quickly explain gaze instability and saccades? Well, gaze stability means, I want you all to try this. You're looking at the screen or something. Turn your head one way and turn your head the other way. You can keep your eyes fixed on me as we go through that, right? That's a piece of cake for you, right? If instead you see a patient who you turn the head and the eyes have to correct, so without, I'm turning my head, but you turn your head away and your eyes have to correct back, that's what's called a corrective saccade. So it's kind of a funny word, but that's a corrective saccade, indicating a vestibular loss. Excellent. Let's see, Zach says, so for both posterior semicircular canals, are they both tested with Dix-Hallpike? Yes. And then finally here, Camilla says, can you please explain the treatment, the habituation exercises? So your gaze stability exercises, it's where you hold out like a fixed point and you practice it. You practice keeping your eyes focused, even with your head moving up and down, side to side, and then you can move the thumb at the same time. That would be gaze stabilization exercises or habituation exercises to make you less dizzy. All right. So with that, let's talk now about question says, can you clarify which side the lesion will be on head impulse testing? It's typically to the side you impulse towards, so the ipsilateral side. VOR1 for unilateral vestibular hypofunction and VOR1 and 2 for bilateral vestibular hypofunction. Yes, short answer is yes. Tyler says, is the head impulse test is positive for a central lesion? Typically, no. The central lesion, you're looking for that pure upbeating nystagmus. Head impulse test is typically testing a horizontal semicircular canal. Or for peripheral, let me make sure I mention a funny term here. Unilateral vestibular hypofunction. Unilateral vestibular hypofunction. What does that mean? Well, it means one side, unilateral, the vestibular system is not working or hypofunction, unilateral vestibular hypofunction. Like I had a patient, this is a few years ago, he had a tumor on his cranial nerve 8 vestibulocochlear nerve. They had to be removed. And so he had unilateral vestibular loss because the nerve had been carved out. And so that was an example of unilateral vestibular hypofunction. Again, a funny term for it, but kind of a description there. All right, other key things I want to talk about here, the spondies. This seems to show up pretty clearly on tests. We've got 4 main spondies. We've got spondylosis. So this is a loss of or narrowing of the intervertebral foramen. Spondylosis. So spondylosis. Essentially, this is degenerative disc disease. So you've lost the fluffiness of the discs. You get a narrowing of the intervertebral foramina, which leads to what is often called the shopping cart sign. They have what's called a flexion bias. What does that mean? Flexion bias. Well, it means that they feel better in flexion, so they'll lean on the shopping cart as they walk, versus some of these other ones where there's an extension bias, like a herniated disc, that'll be an extension bias. Other spondies include ankylosing spondylitis. Ankylosing spondylitis, you get bamboo spine. This is another case where you could get transverse ligamentous laxity in ankylosing spondylitis, but typically you just see the bamboo spine, usually in young to young adult to mid-adult males with stiffness that lasts more than an hour. Spondylolysis, this is where you have the Scotty dog fracture of the pars intraarticularis and potential anterior slippage But then spondylolisthesis is where you have bilateral fracture leading to anterior translation of the vertebra. So the questions I see about this is the questions I see usually are related to, like in spondylolysis, what X-ray or radiograph angle is going to be best for someone with spondylolysis? So spondylolysis, they're going to have that oblique view. So the oblique view, so you can see that Scotty dog fracture. Sarah says, what interventions do you do and not do for someone with ankylosing spondylitis? It fits kind of in the category of rheumatoid arthritis. So same with ankylosing spondylitis and rheumatoid arthritis. Typically, you avoid exacerbating. So it's like, if it hurts, don't do it. But you don't stretch or mobilize swollen and exacerbated joints. And I feel like that fits really well for us as PTs. If it hurts, don't do it. But you can do gentle passive range of motion and active range of motion as tolerated by the patient. Try to increase their mobility without exacerbating the inflammatory response. You'll hate this term too. So a while ago, I tried to stop saying it depends. And so I saw this in a textbook. I would have a symptom-based approach. Symptom-based approach. What does that mean? Well, it means it depends. So if they have leg weakness, I'd try to work on leg strengthening. If they had walking weakness, work on walking. You try to find the deficit and work into it. But the real key is you try to avoid exacerbating any of the inflammatory response in the joints. Excellent. All right. And let's see, what else did I want to say there? All right. So spinal mobilizations, I wanted to mention this briefly. There's a lot that could be said about spinal mobilizations. But the thing I would remember, for most of the cervical spine and thoracic spine, these have what are called the same movement or a same-sided side bending and rotation. So what does that mean? Side bending and rotation occur in the same direction for most of the cervical spine and most of the thoracic spine. That's what you got to remember. That means that if you want to side bend to the right, the vertebrae are rotating to the right as well. So side bending and rotation are a coupled movement. This is because of the shape of the vertebra, that there's a kind of a 45-degree angle on those zygapophyseal joints that as you tip right, it forces it to rotate right as well. So you got side bending and rotation occurring in the same direction. The opposite joints or the opposite rotations would be the A1 on A or OA and AA. So the top of the cervical spine, these are both opposite. And then the lumbar spine. So the way these questions usually come up, a patient with lumbar hypomobility is trying to improve right rotation. Which intervention would be best? Well, if you want to rotate to the right, it means you've got to side flex to the left. And again, it's just because of the shape of the vertebra. Now they're a little bit more vertical. So that's the key here to remember. And there's a lot of nuance to this whole topic, but on test day, typically they want to know if you are understanding clearly the side bending and rotation that are occurring in the same direction in the cervical spine and thoracic spine and opposite for the lumbar and the upper cervical. Excellent. So a couple of questions come across. Can we do some examples of this? So I'll give you the clear examples. And there's a lot of nuance here. Some of you have seen me draw these boxes before, so bear with me here. But if we have a posterior view, and the posterior view, we have C5 and C6. So we're in the cervical spine, transverse processes sticking off each side of the vertebra. The question I have not the question, no question yet. These joints between the vertebra are called zygapophyseal joints, or known as facet joints. Or I had someone that they call them facet joints. Whatever you want to say, these zygapophyseal joints, these are synovial joints that occur or that are on both sides. You get a zygapophyseal joint on both sides. So that's what I'm trying to indicate here with these flat lines. All right, so what's going to happen if we were to side bend and rotate to the right? Let's say we go to the right. What's happening? Well, in order to side bend and rotate to the right, it's going in the same direction. So we side bend and rotate in the same direction. So then the last thing I'll mention here in the same direction, last thing I'll mention here is that side bending and rotation occur in the same direction. This means that you get a closing or approximation on the ipsilateral side and an opening of the zygapophyseal joint on the contralateral side. What does that mean? That means that one side is getting smashed a little bit and one side's opening up a little bit. So nothing more than the words open and close. So it's kind of a funny concept, but if you follow me here, side bending and rotation occurring in the same direction, you get closing on one side, opening on the other. That's the classic example. Now, then the final question is, how do you help? Like, let's say they have difficulty moving into right side bending and rotation. What do you do? Well, your mobilization force is going to help them move in this same direction. So we'll change our colors here. But if we were to open, we could push up. This is what we'd call an up glide on the contralateral side. You see that up glide? It's going to help that C5 to rotate. You could also do an up glide on the opposite side. So what's that doing? Well, it's going to close that joint. It's going to assist with that movement between the two vertebral segments. You could do up glide, or this is the part that hopefully you don't hate me too much for this, but you could also do a down glide. And by down gliding, what we're doing is hopefully you can see with my arrows here that we're basically creating the same rotational movement between the segments. You can down glide on the ipsilateral side, or you can down glide on the contralateral inferior segment. Is that helpful at all? So let me see that. All right. So, and so Lillian says, Will, let's go over this. If patient has decreased side bending to the left, C5 and C6, how would you do mobilization? Yeah. So up glide, down glide, just like we said. Let's see. The question says, I would think the right side would open, left side would close. No, it's what the right side in our example here, the right side bending and rotation, as the right rotates towards the right side, you are bringing the intervertebral facet joint closer together. You're smashing it down almost like you're going into extension on the ipsilateral side. Whereas on the contralateral side, it's sliding up and away from each other. So it's opening on the contralateral side. Alexander says, would the question specify if it's an opening or closing restriction? Yeah, they'd have to specify. They'd be extremely specific. Jordan says, could you use the term unilateral posterior to anterior glides? Yes, but I don't want you to forget that it's not a true PA. So we're going to put a big asterisk here. It's not a true spell. It's not a true PA. Why is that? Why is it not a true PA? Well, it's because the shape of the joint is kind of like you're climbing a hill. That's why there has to be an up glide or a down glide. So it's not a true PA glide. It has an upward movement, has a vertical movement component. So think of your, like, I like snowmobiling. When I was a kid, I really like sledding. I don't bounce as well down the hill if I go sledding, but if I'm climbing the hill, that's up gliding. If I'm sliding back down the hill, that's down gliding. And I just think about that as the orientation of the facet joints. The lumbar, I'm not going to do a lumbar example. It's not likely to show up on the test, but it does follow the same rules here that if you want to, it's an opposite movement. So if you want to rotate to the right, you got to side bend left. And so I think that was an example that came up a little bit earlier was Christopher says, I saw a question regarding lumbar spine, gapping on in side lying. So in side lying, let's say you want to improve right rotation, you'd have them side lie over a pillow or something left. So you're helping assist with left side bending to achieve right rotation. So yeah, just remember opposite. That's the key with the lumbar spine. Excellent. Any mnemonics to do this? No, I have to draw the picture every time. So I'm just the visual learner here. I just have to draw my little boxes and my up glides and down glides, kind of see the circular movement of right rotation in this case. That's what I have to do for that. Excellent. Ansel says, if I leave, is there a recording? A couple of questions have come about recordings. Are there recordings of this? Yes. So I'll post a recording to our crash course dashboard. I'll post it to our VIP course dashboard. I'll try to post a selection to our YouTube channel as well. So be sure to subscribe over on YouTube. Also, I'm not sure if Instagram will let me put up this giant of a video, but I'll do my best. Do my best to post it where you can get it. Yeah, and as Nick says, I'm with Nick. Don't be sad, Angela. You got this. Give yourself a Will Crane fist pump on that. All right, we're going to blast through a few other things here. So speaking of mobilizations, this one shows up. Shoulder mobilization shows up on test day. It follows the same rules that you'd expect. So what are the same rules that you'd expect? Well, it is a convex moving on concave, which means that it has the opposite. So convex concave rule is opposite. So as you roll into external rotation, you're rolling posterior, you have to do an anterior glide for external rotation. So anterior gliding for external rotation, posterior gliding for internal rotation, all that's standard convex concave rule for the shoulder. The weird exception is for adhesive capsulitis. So adhesive capsulitis, this weird exception is that you just do, no matter what, you do a posterior glide because that'll improve both internal and external rotation. And I want to be clear, that is only for adhesive capsulitis. It's not for anything else. So if you have a regular shoulder hypomobility, just follow your standard mobilizations. But for adhesive capsulitis, you will just do a posterior glide. All right, let's see. There's a question. So Bindaya says it's a question about test days and test week strategy. Let's save that, if you don't mind. Let's save that for the end. I'd like to maybe put it in the Q&A box for me. That'd be great. All right, so a couple other acronyms to put on your brain dump page. I just want to talk about a few of them. Brachial plexus. Randy Travis drinks cold beer. So roots, trunks, divisions, chords, branches. So that's a mnemonic device to remember the shape of the brachial plexus. And then finally, we get into some of the fun little acronyms for the radial nerve, the median nerve, the ulnar nerve. My favorite one still to this day is the radial nerve, because as soon as I learned this, I felt like the heavens opened and the clouds parted and light shone down on me. I was like, wow, why didn't I learn this in PT school? The radial nerve is a beast. Abductor pollicis longus, brachioradialis, extensors, anconeus, supinator, and triceps. Since then, it's been a piece of cake for me. So that's what I have the acronym here. I have it listed here. Abductor pollicis longus, brachioradialis, extensor, anconeus, supinator, triceps. The one that's for me a little bit of an oddball is the brachioradialis, because it's an elbow flexor. But if I just remember the word radial is in brachioradialis, it helps me remember that every time. So if I can write down the acronym a beast on my little brain dump, helps me remember what the radial nerve does. The one that, just of note, the posterior interosseous nerve is a branch of the radial. And so if I don't know how to extend my acronym here other than the pin is a beast. I don't know, pin, put on the tack on to a beast here, a beast pin. In any case, it just affects the wrist extensors, but there's no sensory loss as a part of the radial nerve. Let's see. Tristan says, you've reviewed too much when you dream about these mnemonics. That's true. That's true. Progin says, put a pin on the beast. There we go. Put a pin somewhere. But the posterior interosseous nerve, branch of radial. The median nerve, this is the half loaf of pumpernickel. Any of you had pumpernickel bread? It's an ancient grain, pumpernickel bread. Half loaf of pumpernickel, meaning the first and second lumbricals, opponent's pollicis, abductor pollicis brevis, flexors on the radial side, pronator teres, both pronators, that's the P's, both the pronator teres and the pronator quadratus, that's both P's. And then again, maybe I should extend my acronym here, is that the AIN is a branch of the median nerve. So the AIN is where you're doing the tip-to-tip pinching, flexor pollicis longus and flexor digitorum profundus for tip-to-tip pinching. All right. Let's see. So then the ulnar nerve, this is another one that was kind of fun. The mafia, you get the medial two lumbricals, that's the M. Adductor pollicis, flexors on the ulnar side, dorsal interossea, and abductor digiti quinti. The adductor pollicis is the weird one to me because I feel like it's on the wrong side of the hand. Ulnar nerve curves around and gets at adductor pollicis. Anna Kate points out A-OK, if AIN means that you ain't okay, I guess. If you can't do the tip-to-tip pinch, that tells you that you're not A-OK. You ain't okay. My lower extremity ones are not very good. So I guess I present these to you with only a little bit of embarrassment that it's not nearly as good as my upper extremity ones. But the femoral nerve is all down the front of the leg, F quips. So femoral nerve gets the quads, the iliacus, pectineus, the sartorius, and saphenous. It's not nearly as good. F-quips, Q-tips. I couldn't come up with anything as fancy there for femoral. I just memorized it's on the front of the leg. The saphenous nerve, this is a sensory branch. Branch on the medial side. Branch on medial side. So the way I remember that is that the sural nerve, which sounds a lot like it, the sural nerve is a branch of the tibial. Sural nerve is a branch of tibial, and it's on the lateral side. And the way I remember that is that there's an L in sural, which means it's on the lateral side. So there we go. Alexander says the femoral queens hardly get time to sip coffee. Oh, I like that. So queens hardly get time to sip coffee. Sip coffee. Yeah, I like that. Okay. Other ones here, we got the deep peroneal. This one is DPTEEEE, deep peroneal. Gets your tibialis anterior plus a ton of extensors, extensor digitorum, extensor digitorum longus brevis, extensor hallucis longus brevis. Superficial peroneal is the peroneus longus brevis, and finally tibial is the gas plant. Again, take this with a grain of salt here. Tibial nerve is the gas plant. We get the gastrocnemius soleus plantaris, tibialis posterior popliteus, and the flexors digitorum, flexor digitorum and flexor hallucis longus, both those for the tibial nerve. Just not too much of a side note here, but maybe some of you know this. It was so dumb. I was in a four-wheeler accident earlier this summer, so about 6 weeks ago, and it just rolled over right on top of me, and it shot my femur. It hit my leg and shot my femur right out the back of my pelvis, and so I have a posterior acetabular fracture. And so I spent a couple days in the hospital, and they had to surgically repair it. So in fact, I still have my crutches here, so I'm crutching around non-weight bearing for a few more weeks. But in any case, the part that's annoying and also terribly in a sadistic, interesting way is that I'm having neuropraxia and nerve pain along my sciatic nerve distribution. And remember, the sciatic nerve is a bundle of the common peroneal and the tibial nerves. And so I feel like, so the deep peroneal nerve has a sensory branch. Do you remember where the sensory branch is? I can feel it right now as we're talking here. Where's the sensory branch of deep peroneal? Well, it's the web space between first and second web space. So it's so funny to me. As we're sitting here talking, I feel like the web space between my first and second toes is on fire. It's just kind of a slow burn fire, so it's not like a crazy fire, but it is a neuropathic type pain, which is super annoying, let me just tell you. But I am okay. I only tell you that because it's, in my mind, it's terribly interesting that I have such a clear distribution of my deep peroneal nerve right now on my left foot. And anyway, I feel like my DPTs, you're the only ones I can tell about things like that, and you'll understand. It's like, oh, that's cool. Anyway, so on the mend, I'm doing good. I have no complaints, but it is super funny to me. All right, talking about some of the claws here. So I wanted to mention the 4 claws here. We've got the median claw. This is when you attempt to make a fist, but the first 3 digits don't move. You've got the ulnar claw, where your hand is at rest, and the 4th and 5th are kind of stuck in flexion. So that's loss of lumbricals. With the ulnar nerve, that's an ulnar claw. You've got the deputrens contracture, which looks a lot like it, but it's because of a tightening. So I have a patient right now who has super tight palmar aponeurosis and palmar fascia, which means that they cannot passively extend. It's just so tight with deputrens. And then finally, the other claw I wanted to mention is Klumpke's claw, or Klumpke's palsy, which is loss of the lower brachial plexus. You get all of the fingers that are kind of stuck in a claw formation. So all that to say, there's 4 main claws you've got to know. You got your median claw, loss of the median nerve, so you can't move the first 3 digits very well. The ulnar claw, which is where with the hand at rest, the 4th and 5th are they're not stuck, but you just don't have the lumbricals to extend those fingers. And so you could passively extend them, but they just are going to be at rest with the ulnar claw. The deputrens contracture, which is actual fascial tightness. So that's a tightness or nodules of the fascia. And then finally, Klumpke's claw, which is loss of the lower brachial plexus, where the digits, the loss of the lumbricals, and all the digits lead to this claw type formation. So how's that for the 4 claws that you're going to run into on the test? You've got ulnar claw, median claw, deputrens contracture, which is not really a claw, but it kind of looks like it, and then Klumpke's claw, which is the lower brachial plexus. So Brennan asked a great question. Which one is the hand of benediction or bishop's hand? Now, most of the time, well, I got to be careful how I say this. It's different in different textbooks, and that's super annoying. And so that's why I avoid the term benediction hand or the papal sign or the hand of benediction. Historically, those of you who want to go down the historical rabbit hole, most textbooks list a median claw as the hand of benediction, but they're kind of wrong because it was not likely. The theory was that one of the early popes had a nerve injury, which meant that they were always in the papal sign or the papal formation here with the hand. But it's not likely they were trying to make a fist to fist bump their congregants. Rather, it's more likely that the Pope had a ulnar claw with an open hand, and so it's more likely it was an ulnar lesion than a median lesion, because the blessing was most likely going to be done with an open hand, and they weren't going to be fist bumping all their congregants. So uh, Philip brings up a good point. Why can't all textbooks be the same? So if you want to go down a little bit of a Wikipedia rabbit hole, check out Hand of Benediction, and you'll see that I think most people have turned back to ulnar claw as the most likely definition of the hand of benediction. But just of note, it can appear on both in different textbooks, and it's super annoying. So yeah, Brendan, long answer to a short question. And so I'm just going to stick with what nerve is the problem. Median, ulnar, and then Klumpke's claw. Erb's palsy, that's the upper brachial plexus. You lose the ability to flex the arm, so you're stuck in what's called the waiter's tip deformity. That's what this image is showing, is the upper brachial plexus. All right, so we've gone through some of that. Let's talk about math on the NPT. So let's talk about math on the NPT. So as an example of what could be math on the exam, they do not give you a calculator, which is kind of a pain, but the math on the test is going to be straightforward and pretty, I don't want to say simple, but it will be clear what the math is. So as an example, what you could do is like Carvonen's method. Carvonen's method simply looks at your maximum heart rate, so your age predicted maximum heart rate, minus your resting heart rate for what's called the heart rate reserve. And I want you to think about that for a sec. Like, your heart rate can only go to the bottom. Like, the lowest it goes is your resting heart rate, and the highest it goes is your age predicted max. And so that difference between your high and your low is what's called the heart rate reserve. So then you just calculate percentages of your heart rate reserve. So just as an example, let's say that we have a patient is 60 years old. So our patient is 60 years old. So their age predicted heart rate maximum is what? Age predicted heart rate max is 220 minus your age of 60, or a 160 heart rate max. So that's your age predicted heart rate max. For ease, we're going to give the heart rate rest to be 60 beats per minute. You can see where I'm going. So that's your heart rate at rest. So therefore, your heart rate reserve is what? Heart rate reserve is your max, your maximum minus your minimum for a reserve of 100 beats per minute. I mean, that's how much your heart can give. Your heart can only go from the bottom to the top. That's the give on the heart rate reserve. So then you just calculate percentages of your heart rate reserve and add it back to your heart rate at rest. That's your Carvonen method. So let's say, just to finish out our example, let's say we decided that our target was going to be 70%. Let's target, we're just going to say 70%. So we do 70% times our reserve, which is 100. So you can see really easy math here. So 75 beats per minute. And then the final step is to add it back, 70 beats per minute. And we're going to add it back to the heart rate at rest. So 60 heart rate at rest plus 70, the heart rate reserve target, for a grand total of 130 beats per minute would be your target heart rate during exercise. Is that clear? It's kind of a pain, but it is an example of a type of proportion math that could show up on the test. Other types of math that could show up on the test would be like the ankle brachial index. Question comes back. Angela says, how did you get to 70? It was given. So I had to tell you what the target was. Progin says, what if they give us an intensity? What if they give us intensity? Do we need to calculate that as well as part of the Carvonen method? Yeah. So you just calculate your percentage of your heart rate reserve and add it back to your heart rate at rest. So in this case, we gave 70% as your target heart rate, and then just add it back. And you could do it for 40%, do it for 85%. You could do it for anything in between. That'd be an example of what you could do on the test. The ankle brachial index, another example of a math on the test, ankle brachial index. The name is how you calculate it. The ankle to the brachial blood pressure. So the systolic ankle blood pressure to the systolic arm blood pressure, brachial blood pressure, and you just divide. Basically, it's just kind of a pain, long division. But as an example, let's say that your ankle blood, let's see, do I have an example here? Let's say your ankle blood pressure was 100 and your uh, arm or brachial blood pressure was 120. So we need to do long division. This is a pain where we need to do 100 divided by 120. So if you were to draw your long division brackets, what is it? 100 divided by 120. So how many times does am I doing this right? Yeah. How many times does 120 go into 100? Oh my goodness. What if I'm doing this backwards? 100 divided by 120. Yeah. How many times does it go into it? Well, it doesn't. So you have to add a zero. We're going to add a zero here. It goes into that. So what is that? 8 times. So it goes in there 8 times. 8 times 120 is 960. You're left with 40. Doesn't go into that. So you have to add another zero on the end of this. So how many times does 120 go into 40? It goes in through 3 times. And so 3 times 120 is 360. And we're left with 40 again. And you can see it'll be 0.83 repeating. So that's an example of math on the test. It's kind of a pain. You can see while I'm doing it live, it's kind of a pain as well. All right, let's see. Sarah says, what's the AB value where PT is contraindicated? When is it contraindicated? Symptom-based approach. Usually it's contraindicated when you have severe arterial disease, so less than 0.5, but you could make an argument if they're symptomatic, severe symptomatic, you'd be 0.5 to 0.8. So it would be a symptom-based approach. Very much a symptom-based approach. All right, so now I've got a trick question for you. Are you ready for this? Of course you're ready for this. This is a great time too. I'm going to roll out a poll box. And so I'd have you click your answer in. Don't type it in. Please click your answer in. We're getting close to the end here. This would be a great time to queue up any questions you have for me that, burning questions you want me to make sure I answer. Now is a great time to start queuing those up. I'll be quiet while you respond. Ready, set, and go. All right, we'll go just a few more moments. All right, so this one, it's funny. Let me show you the poll results so you can see. So you can see the results. We are divided almost exactly 50-50 in the class. And this is going to be a painful one, but now you'll not get it wrong on test day because we talked about it. A patient's receiving NMES with an on-off ratio of 1 to 4. What is the duty cycle? Well, the duty cycle, we have to define our terms here. Duty cycle is what? Duty cycle is equal to on time divided by on plus off time, or what's considered total time. So in this case, our on time is, let's put some unit to this. Let's say that our on time is 1 second, and our on plus off time, the total time of a cycle, is 1, that's our on time, plus 4 seconds off time, for a grand total of 5. So therefore 1 divided by 5. So your correct answer is 20% duty cycle, 0.2, because it's 1 divided by 1 plus 4 for 20%. Give me a thumbs up or a thumbs down on that one. That's a painful one because you probably memorized on-off cycles. You probably have memorized the ultrasound. You got like a 50% duty cycle and whatever. But glad we went over that one. That 20% duty cycle is on divided by total time. Excellent. Josh says that would have caught me. Good job. Good point. Yeah, that's one that got me too. I remember seeing a question like that and having to say, what? Wait, okay. Duty cycle on divided by on plus out. It's the cycle, the entire cycle of time here. Excellent. Trang says, I did not know I had to do math for the duty cycle. Thank you for this. Let's see. Question comes across. Jessica asking about temperatures for aquatic therapy. Do we need to know the degrees Celsius or Fahrenheit? They'll put both. It'll be one of those things where, so and so degrees Celsius, so and so degrees Fahrenheit together. That'll be both. Let's see. Libby asks a great but very complex question about how to figure out compensated, uncompensated feet. I'll see if I can have time. That one's kind of a tricky one to just say versus draw out. Last thing I wanted to talk about, just as we're talking about numbers here, as we get to the conclusion here, ADA requirements. This is another example of numbers that could show up on the test. So just interesting and important numbers you need to know. Another example of some math would be the sloping of ramps. So a ramp slope, according to the Americans with Disabilities Act. So this was an act passed, when was it? 1990, 1989. So it's been around for 35 years. The ADA requirements were written with, we'll call English or imperial units rather than metric units. And so that's why there exists this 1:12 ratio with the idea that it's 1 inch for 1 foot or 12 inches. So it's a 1:12 ratio as a ramp slope. So as an example, let's say that the ramp height, let's say our target ramp height is going to be, I don't know, let's say 24 inches. So 24 inches. What must be the ramp length? So what is the ramp length for something that has to go up 24 inches? Well, the easy math is 24 feet. The trouble is they're not going to give it to you that easy. They're going to give it to you in inches, which is 24 times 12, which is 288. So it would be 288 inches. So that's going to be painful on test day, right? Something like that. Another interesting thing about ramps is that their maximum length, it can only be 30 feet before you have to have a landing or a rest period, or a resting area, and continuing up again. So you can continue, but you just have to have a rest area somewhere. And so 1:12 ratio, which of note, what is the percentage grade? What is the grade percentage? Well, the grade percentage is 1 divided by 12, which is actually pretty similar to the same math we just did a moment ago. It's 8.3%. So an 8.3% grade, meaning for every 100 feet, it would go up 8.3 feet. So it's just, again, that's another way to write out what the ramp slope is on any given ADA ramp. Other things of note here is your carpet pile. This was one that was annoying to me. What in the world is carpet pile? It's carpet pile. That's how fluffy a carpet is. The carpet must be not very fluffy. It has to have less than a ½ inch of carpet fluff, just because a wheelchair can't travel through it very easily. Doorways 32 inches. Hallways have to be at least 36, with ramp landings 5 feet by 5 feet. These are all examples of what could show up on the test. Excellent. All right, so there you go. That's our ADA requirements. All right, let's talk now about, I'll polish up with some of the content questions here in a sec. Let's talk about test day here for a minute. So test day is coming up. There was a question that came up earlier about what do we do this week before the test? Let's see, what it is. Here it is. Question says, I'm taking the test on July 24th, so 2 days from now. What should this week look like? So all I can do is tell you what Will Crane would do with test week and what I did do. So I have heard the advice that you don't study the day before the test. And I actually hate that advice, because I would go crazy just sitting in my apartment watching Netflix or something. Like, that would make me just absolutely go bananas. So what I do is kind of a version of studying, but I'll call it relaxed studying. And what I mean by that is it's a great time to review like 5 practice questions at a time. Things you've seen before. Chances are it'll be an exam you already looked at. Review a few practice questions, review their answers, take a break. Review a few practice questions, review their answers, take a break. You could also review flashcards as an example of your flashcard deck. This is what I personally did. I sat in my easy chair, beautiful window, and I just, just went through a few flashcards and I went slowly. There were things I already knew. And so I suppose the exam or the advice of not studying the day before the test is meant to say, don't try to learn new material the day before the test because you already know what you know. And so what I suggest is just looking at and reviewing things that you already know in a way that's going to make it stick for test day. Very relaxed. We're in the summer months, so maybe you can find some outdoor environment where you can sit and review lightly some of the content you've already looked at. So Meredith says, "Thank you for justifying studying the day before." Yeah, I would. I've heard of people who yeah, the night before the test, I go and watch a movie with friends, and I just shake my head like, I mean, I guess, but I feel like I'll be thinking about the movie the whole day of the test. I'll be staying up too late. I'll just be out of schedule. So I can only tell you what I would do, and I would do relaxed studying, very casual, lots of breaks, lots of exercise and outdoor time. I'd be extremely, extremely, extremely relaxed on that. All right. Other test day items. Question says, do we need to bring the authorization to test form with us to the test? I don't think you have to. In fact, I'm fairly certain you don't have to because the ATT is what was required to make your test appointment. But me being who I am, I like to have it printed out and ready. Just it's no problem at all. Just put that in my back pocket. If you ask, certainly I can show you my ATT, but they're not going to need it. Rather, what you do need is your two forms of ID. You'll arrive early, make sure you get checked in. Can I tell you another horror story that I had? I had a student who she arrived early to the test and the test site was just opening up. It was like an 8 a.m. test, just opening up for the day. And the test staff said, okay, yeah, we see you here. We haven't turned on the computers yet, just getting booted up. Take a seat in the waiting room and we'll come get you when we're ready. So she sat there for 10 minutes, for 20 minutes, for 40 minutes, for 60 minutes. She's sitting there just kind of jittering in the waiting room. Like, when are they going to call me? Like, what's going on here? Finally, I think it was like an hour and a half or so after her appointment time, she walked back to the test staff and said, hey, like, just let you know I'm still here. Oh, we didn't think we put you down as a no-show. Like, it was one of those things like, no, you're kidding me. And so she failed the test. Super, super just jittered up. She was starting late. It was just, everything was bad about the whole day. So be your own best, be your own best advocate on test day, which means you walk in, you check in. If they tell you to wait, like, I'm back to the desk in 5 minutes, maybe 8 minutes max. Like, back, hey, did you forget about me? Just because I guess again, that's me, that I don't want to be forgotten, left behind. Other things to remember, this was a fun one, is on test day, they're going to take your picture like 5 times. So they're not going to let you cheese it. They don't let you have like a cheesy smile. But I do want you to sit up straight and have at least a pleasant look on your face, because you've got to look at your own picture back again. And if you have a sad, defeated look, you're going to be, it's going to be a pain. So stand up, sit up straight as you walk in the test. Good posture. There's a lot of evidence that goes behind good posture, having a power pose. Super a lot of evidence there to lower blood pressure and improve performance. I already talked about dress to impress. PTs, we are fabulous at looking good, but also being comfortable. So like, I'm wearing a polo right now as an example of, maybe I don't look fabulous, but at least, I don't know, some of you could disagree with me there. Maybe I don't look fabulous, but it's extremely functional, and it gives us more of a professional look than if we showed up as in our, scrubs or pajamas, like dressed to impress. Most of you, if you're like me, are going to get this fatigue that will set in around the third section. That third section, I suggest taking mini mental breaks. Mini mental breaks. So what does that mean? A mini mental break is where you close your eyes, you look at something far off, like a far off clock or a wall, and just take a couple of deep breaths and relax your eyes. Give your eyes a chance to calm, and give your mind a chance to calm and focus again, and then re-engage with the test. And how do you know when to do it? Well, do a lot of self-analysis during the test, where you're asking yourself, all right, am I at 100% performance? Yes or no? If not, then that means I need to refocus. If I am, great, then I continue on. And so lots of mini mental breaks. You are permitted to take a scheduled break between section 2 and 3. 15 minutes, it's the bathroom break, go get your snack, everything's great. You can take unscheduled breaks between any other section, but those deduct from your overall time, which means that you've got to really hurry. That's like the emergency bathroom break. So be very cautious of that. All right. Paula says, what are your thoughts on taking an additional break in addition to the standard 15 minutes? Is it a hassle to go out and in? It is a hassle, and I suggest only doing it if it's necessary. So as an example, emergency bathroom break, I would use it. Or if you have additional time, so some of you here have test accommodations with time and a half on the test, you may consider taking a break between any of the other sections. Catherine says, been enjoying the NPT podcast with Will's wonderful voice for a daily dose of study. I'll pay you later for that comment. Thank you. Yeah, the NPT podcast, I enjoy doing. I've been kind of on break because a lot of things going on. My life is a little busy right now with the broken hip and everything, but I'm going to get back in. I try to do 3 a week on those podcast episodes. So you got to check that out, the NPT podcast. Lillian says, I was very tired after spending 36 hours at the airport. I know some of you were traveling for the test and the big computer outage got you. But now feel very motivated again. Thank you, Will, all the colleagues. Best podcast, hands down. Let me tell you, those of you who are not a part of any of our classes, your price of admission today is go leave me a review on that podcast. It really helps in the algorithms. Just go hit 5-star review on wherever it is you're listening to the podcast. That'll help a ton. All right. Sydney says, are there any good ways or strategies to remember lab values? If it's less than 8, so hemoglobin, if it's less than 8, don't ambulate. Ambulate. Can't even spell ambulate. So that's an example of how I'd remember hemoglobin. So what is it? 8 grams per deciliter. If it's less than 8, don't ambulate. Hematocrit, same thing. Usually it's around 45%, but if it's, what is it? If it's less than, oh my goodness. If it's less than 30, oh my goodness. I'm not going to say it because I might have forgotten it, but normal is around 45%. It's different for males and females, but hematocrit's about 45%, less than 25. Thank you. I was trying to say 30, but it's really less than 25. If it's less than 25, then you don't ambulate. But usually it's around 45%. Oh, my lipids. So I like my lipids. So this is another fun one for lipids. It's your blood lipid panel. If you can remember 50, 100, 150, and 200, you can remember your lipids. So we know that 50 represents your HDLs. You need to have lots of those. So HDLs need to be greater than 50. And that's because these are the happy or high density lipoproteins. Your LDLs need to be less than 100. Your total, your triglycerides need to be less than 150, and your total cholesterol has to be less than 200. So if you can remember 50, 100, 150, 200, you can remember your HDLs, your LDLs, your triglycerides, and total cholesterol. All right, let's see. That's that. Jorge says, next year I'm going to take the exam. Which book do you recommend? All the textbooks for sure. I recommend you take our VIP course. So the VIP class that we talked about at the start of today. So the VIP class is one that I run every quarter. We go through, you get access to, we have a study guide that's included in that. We have a full video library. It's a small group setting, so you're able to get all your questions answered. Like today, I'm just sorry, I'm not going to be able to answer everyone's questions, but in our VIP group, try to answer everyone's questions. We have a small group study session twice a week, every week. We've got, like I said, a video library, one-on-one power calls. Those are the most fun for me because I get a chance to talk to each of you one-on-one. So that's the VIP class. That's what I would very much recommend. Bobby asked a good question. Is this for PTs or PTAs? It is scheduled around the PT test dates, but it's extremely applicable to PTAs. And we have a ton of PTAs that join us over the years. I've had tons and tons of PTAs. So very much welcome. Very, very, very welcome. Anna Kate says, yes, highly recommend the VIP group. Yes, Anna Kate. Very awesome. All right, let's see. So what other questions do you all have? So as we come to a conclusion here, let me just make sure I'm hitting some of the questions. Another question comes up. Any trick to remember myasthenia gravis versus multiple sclerosis? Myasthenia gravis, so MG, the key with myasthenia gravis is you have weakness with repetition, or we're just going to say weakness with repetition. So it means that you have good strength on your first shot, but then as you do the activity, it gets weaker and weaker, very, very rapidly, very rapid degradation of strength. Whereas multiple sclerosis, you have a lot of upper motor neuron signs. You got positive Lermite sign. You get lots of weakness, but fatigue is a real key. So fatigue, heat intolerance, these are all keys for multiple sclerosis. All right, let's see. Gabrielle points out myasthenia gravis has no sensory deficits. Jaquetta says, with spondylolisthesis, do we avoid extension or flexion? You avoid extension with spondylolisthesis. Mariah says, can you go over the different cauda equina versus conus medullaris? Well, cauda equina, I guess just put it very simply, cauda equina is the horse's tail. These are all the separated nerve roots in the lumbar spine. So you'll have lower motor neuron signs, whereas the conus medullaris, this is the end of the spinal cord proper. And so you'll have mixed upper motor neuron because it is in the end or the terminus of the spinal cord. All right, let's see. Other questions. Lillian says, very quick about discharge planning. Where do we send the patient to? So when it comes to discharge planning, let's see if I can put it, let's see. Discharge planning. You want to send them to the highest function possible. So it means if they are independent, you will send them home, right? If assistance is required, usually if it requires, almost always, if you require anything beyond min assistance, or it requires two people, so two-person assistance, usually they're going to the nursing home, skilled nursing facility. And if it's min assistance, they're going to a assisted living center, assisted living facility. So assisted living as an example. So that's an example of discharge planning. Let's see, going through a few of these things. Amber says, any helpful tips on hypo and hyperthyroidism and hyper and hypoparathyroidism? So if we were to just do that, if we were to do that in just the briefest terms, hyperthyroidism. This is also known as Graves' disease, Graves. So the key with hyperthyroidism is you have excess metabolism. So these folks have weight loss, heat intolerance. They run very hot. They also have the exophthalmos. And I told my VIPs, I had my first ever patient with true Graves' disease, and her eyes were like wild. It was gnarly. It was right out of a textbook. That's hyperthyroidism. Just of note, the opposite is true for hypothyroidism. Hyperparathyroidism. I just remember that in my mind, parathyroid is associated with serum calcium, so blood calcium. So the parathyroid with blood calcium. So hyperparathyroidism is going to have excessive blood calcium. And you have to ask, where did all that calcium come from? So you have bone mineral loss as an example with hyperparathyroidism. Good. So there you go. There's some of those little tricks there. All right. See if I can catch up. I'm going to skip down at like 51 new messages on my chat box here. Let's see. All right. What other questions do you have for me? Carolyn says D1, D2 patterns. So it's P and F patterns. D1, you pull off your earring and throw it away. D2 is you pull the sword out and hold it over your head. So that's the D1, D2 patterns. Jessica asks a really good question over in the Q&A box. Jessica's question is, how much knee range of motion is usually required to complete a full revolution on a bike and sit to stand with and without compensation? I came across a few practice questions related to this. Can't find a good resource. I believe most of the time it's, well, to ambulate requires 60 degrees of knee flexion. So let me bring your question up, Jessica, and maybe someone can jump in here, help me out with my answer. But Jessica's question is this. How much range of motion is required to complete full revolutions on a bike versus sit to stand? I believe normal is around 90 degrees. Someone will have to tell me. 60 degrees for gait. Let's see, some chat coming in that it has to be above 90 for a bicycle. I know that going backwards on the bike requires less knee flexion because it forces the hip into more flexion. A lot of consensus on about 105 degrees for full revolution. But it depends. I hate to say it depends, but it totally depends on seat height. So totally depends on seat height for both of these. But I think the general answer is greater than 90 degrees. Fox 105. There. How's that, Jessica? Little consensus from the group. All right, we'll just finish up the last couple of questions here. Quick question about diabetes. So diabetes and blood glucose. Blood glucose. So normal, or we'll call these safe levels. Safe levels are between 100 to 250. What is it? Milligrams per. There's grams per. It might be grams. Grams per deciliter. So that's a safe zone. It's milligrams. Okay, not grams. Milligrams per deciliter. The caution zone is between 250 to 300 because that's when you can start to get signs of ketoacidosis, diabetic ketoacidosis. And then the contraindicated is anything greater than 300. And that's because once you get above 300 milligrams per deciliter, it puts you at an extreme risk of diabetic ketoacidosis. So these would be we'll call these the casual blood glucose levels. Casual blood glucose levels. Let's see. Christopher says, let's see, question comes across. Christopher, can you message me privately about that one, about helping out with PTFE? That'd be great. That'd be really great. All right. So we talked about diabetes. All right, let's go ahead and come to a conclusion here. So I just want to tell you thank you. I guess that's the biggest thing is we come to a real conclusion here. I know we've been going for a long time. My hope is that this has been helpful to you, that we've gone over some things that are needful, necessary. You've seen on practice questions. I hope that it's been helpful as we've talked about some of these mnemonics and memory tools. The biggest thing I want you to do when you walk in on test days is just remember that this is what you're good at. This is an intersection of your skills, what you're good at, and your interest, what you love doing. And so I just want you to know that it's a good and noble thing, what you're doing. As you walk into the test, I've heard some people say when you walk in the test, it's like you're going in to treat, in this case, 225 patients. You're going to go in there and treat 225 patients. I find that a little stressful to think about 225 patients, but I do like to think about that it is something that is going to assist me, be a stepping stone for me to help patients in the future. And so, yeah, I want you to know you're doing a good thing. So with that, we'll go ahead and bring today to a conclusion. I'm glad it's been helpful. I will get this recording posted again to like our crash course pages, to our VIP pages. I'll try to get some selections as much as I can posted on our YouTube channel and Instagram as best I can. Remember, the price of admission for coming here today is you have to go leave us a review, a 5-star review over on the podcast, on the NPT podcast. So that's your price of admission today. I'm glad it was helpful. Brennan says it was super helpful. And the biggest thing I want to say is good luck on the exam. Let me know how it goes. Those of you who are targeting a future exam, please consider joining us for our VIP group. I will be praying for you all. I know that you can do this and you will do this. So with that, Will Crane fist pumps all around. When I was in the second grade, anytime we got something right, there were 20 boys and 6 girls. Us 20 boys, we'd all give ourselves a little yes, yes. I want you to do that. Give yourself a little fist pump as you walk into the test, as you get things right, and as you finish the test. Little fist pump when you get it right. So you got this. Have a fabulous, fabulous day. Let me know how it goes. I'll talk to y'all soon. Take care of yourselves. Good luck on the test, everyone. Thanks.